We now turn to our fourth panel segment titled Looking Ahead, Implications of Broadband Connectivity as a Social Determinant of Health Domain on Government Policies, Clinical Care, and Health Equity. This panel discussion will be moderated by the President of the Commonwealth Fund and former National Coordinator for Health Information Technology, Dr. David Blumenthal. Dr. Blumenthal, please proceed. Dr. Blumenthal, if you can unmute, please.
A Zoom hazard. These are our panelists. We have a really packed agenda. I'm not going to talk about myself. What I'm going to do is introduce our first speaker. And after that, the speakers know the order in which they are to enter the conversation, and I will leave it to them to introduce themselves. I gather from listening into the previous conversation that the concept of broadband as a social determinant has surfaced and been discussed at some length. And the focus of this panel is more on what the implications of that determination are and what we can do to expand the availability of broadband. We're going to start with John Horgan. John?
Thank you very much, David. And I was going to show a couple of data point slides, and if we can get those up and go right to the next one, we can get started. I want to make a couple basic points about broadband and healthcare disparities. We know that healthcare outcomes are often a function of where people live and how much money they make. The same is true for having a home wireline broadband subscription. Why do I focus on wireline? Because it's a far better means of connecting for applications such as telehealth than data cap limited cellular data plans, which is something that many low-income households rely upon only for their internet service. And you can see from this slide that just under half of those in poverty have wireline broadband subscriptions, much lower than middle and upper income households in the United States. And it's also the case that the pandemic was very impactful on low income households. They struggled to maintain connectivity, with close to 20% having lost service during the pandemic. Now, the emergency broadband benefit helped. The data show that about 1 in 10 low income households are connected due to a discount program. But data also shows that notwithstanding those figures, that lots more has to be done to get the word out about EBB's successor program, the American Connectivity Plan. Next slide, please. The other part of the story in the next slide is the place and race element. These are just some data points collected on cities in the United States, and it shows that cities with high poverty rates have lower broadband adoption rates than cities with less severe poverty problems. And residential segregation also matters. Places with this historical legacy, like Baltimore, where I live, have lower broadband rates than cities with less pronounced histories of residential segregation. In some very poor neighborhoods, which have historically been redlined in Baltimore, I estimate that only 1 in 4 households have service at home. So to the next slide, we can talk a little bit about what we know about solutions. First, it's the case that healthcare can be a motivator for getting online, but it's important to invest in messaging from trusted local institutions in order to get the ball rolling to get people without broadband with broadband at home. It's also the case that digital skills training can be a force multiplier in that those who have had digital skills training are more likely to use the internet for healthcare information. The big elephants in the room that work against some of these adoption patterns is trust. Trust is a big hurdle for low-income populations when it comes to getting broadband at home. Sometimes low-income households think discount offers are too good to be true. Others think that if you get internet at home, then business and government is going to be tracking their personal information. At the same time, an important model to think about in giving people the help they need to get online is the digital navigators model. You talk to practitioners in this space, and they always say that getting people online is a boots on the ground challenge. You need to hire people from the community to communicate with those in communities with low broadband adoption rates. And that's a very good technique going forward to consider on how to close the broadband adoption gap, particularly in light of significant amount of funds having been appropriated for digital skills. So with that, I will turn it over, I think, to Joshua Edmonds, who's next. So I will conclude. Thank you.
Joshua, please remember to introduce yourself.
Yep. Thank you. I'm Joshua Edmonds. I'm the Director of Digital Inclusion for the City of Detroit. And I also have the pleasure of serving on the FCC's Intergovernmental Advisory Committee. Specifically, my job is to lead the telehealth work group. But one of the things I want to highlight today, I have 3 points, but one of them is really on the role of municipalities. As I mentioned, the Director of Digital Inclusion, I started that role January of 2019. So for those folks who are keeping score, you realize that is before the pandemic. And I think at that time, a lot of the work was just getting the word out about, hey, there's a digital divide. Municipalities, specifically urban municipalities like Detroit, we didn't really receive robust federal funding. There wasn't ARPA funding, there wasn't infrastructure bill funding. And quite frankly, when the pandemic did hit, a lot of the groundwork that, John had mentioned in his presentation about building trust, we were able to do that. But as we looked at some of the effects that COVID-19 had on Detroit specifically, it ransacked our community. And so much so that the state had created a racial disparities task force on COVID-19. And off of that, we were able to do a telehealth activation called Connecting Seniors. That program allowed us to essentially connect 8,000 seniors and their caregivers in the Detroit region with devices, technical support, as well as a telehealth application that was developed in partnership with Wayne State University, Accenture, and Microsoft. And the reason why I'm highlighting this effort is specifically for those municipalities that do not have the telehealth capacity. Now, as you're looking at the infrastructure bill funding, as you're looking at some of the ARPA funding, you might say, well, that could be some funding to help us stand up something. And for us, whether we stand up a municipal telehealth effort, I think that there is a specific call to municipalities in being able to facilitate telehealth outside of our walls. These are still our residents. And quite frankly, our role in that endeavor was, being a supporter, a facilitator, and an amplifier. We were able to say to the state that telehealth at the intersection of the digital divide is a priority for us. And I would, implore other communities to do the same, especially with some of this funding that's going to states. But at the same time, some of those core partners in that arrangement, one was Focus Hope. Focus Hope is a nonprofit here. They've been around for close to 50 years now. And their role there, they already were running a food delivery program throughout the city of Detroit that seniors were already relying on. And so for us, we didn't want to start at zero. We wanted to look at existing momentum and then be able to support people accordingly. In addition to that, we worked with a technology refurbisher by the name of Human IT. These people are used to getting devices out to people who need them. They're also used to providing technical support. Again, we're not starting at zero here. And so for us, we looked at the pieces and parts in the room and we said, all right, well, who else is missing? Well, the university. We know that universities play a critical role in not only advancing dialogue here, but in some cases, even providing that telehealth support to residents. And so that's something where we were able to highlight that. So my very first point is really looking at the municipalities, specifically those who might not have telehealth operations or functions. We can still be effective in this arena, and we absolutely do need to be present in these conversations. In addition to that, my role in the Intergovernmental Advisory Committee, we are going to be releasing the 2022 telehealth report. We're very excited about that. It's a very nuanced report. I'm going to highlight that now. The way that we're doing this is in more of a matrix style. And what I mean by that as we have about 19 different government offices represented, some tribal, some county, some municipal, some state. Our whole role is to make recommendations, obviously, to the commission, specifically on expanding telehealth access. We're doing everything from looking at software and interoperability and language access, all the way down to just basic digital literacy recommendations to the commission. And so I think that in that role, we'd like to be able to highlight and say that report is coming. We do want to have that released this year, and the level of nuance that we're using there, we do want to actually spur a larger and broader discussion on telehealth. I was looking at some of the other panels today where they said we don't have a plan specific to getting broadband to every single American. And I think that that is something where telehealth absolutely needs to be a part of that discussion. And I believe that the report that we're going to be releasing this year will absolutely allow us to accomplish that objective. I don't have much more else to say beyond that, and look forward to what other speakers have to say. Thank you.
Great. Thank you very much, Joshua. Perfect timing. Our next speaker is Mikkel Moore from the Intermountain Healthcare System in Utah.
Thank you, David. So I'm Mikkel Moore, Chief Community Health Officer for Intermountain Healthcare. Intermountain is an integrated system serving an 8-state region from Canada to Mexico borders, essentially in the Intermountain West. And about 50% of the care we deliver is provided in value-based arrangements, meaning we're prepaid for those, allows us to think about whole person health. And that really has driven the way we think about broadband access in the context of telehealth capability, but also the way it enables access to addressing people's social needs and the determinants of their needs overall, education, job access, et cetera. We're also in a part of the country that has a lot of rural communities. And as I reflect on some of the data points that were outlined in the beginning, I just want to call out that in rural communities, access to broadband, whether people can afford to pay for a subscription or not, having access to broadband is a really significant issue. About 1/4 of rural residents in our country don't even have the option to purchase broadband. And so when we think about this in the context of care delivery in the work we're doing, as well as addressing social determinants, it's a very real issue. We've done lots of similar things to those I heard discussed in the previous panel in terms of facilitating access to care close to home. Using telehealth, the pandemic has helped us to do that. And we've built out a lot of capability in rural hospitals, rural community clinics, and in schools across our service area to improve connectivity for healthcare services specifically. But even as we've been doing this, we've been screening our patients and members and community members for social needs. We fund community health workers through community-based organizations that during the pandemic were able to reach out to people who were high risk and assess their needs. And interestingly, about 30% of people are indicating that they have utility and broadband needs. Even while community health workers were initially focused on things that were more seemingly higher in the Maslow's hierarchy of needs. And that's, of course, because broadband is so critical to connecting with others, getting access to food, applying for a job, going to school, and doing a job often. And so, when I think about this as, what can we do? What's the go forward on this, David? I see a call to action. First, for policymakers, we know policy level interventions have the greatest ability to help the most people. We should think of broadband as a utility just like power. We need to have universal access and availability, and the assistance programs that are available to those who are unable to afford to have assistance in getting access to broadband universally and facilitated in that access. For health systems, we need to do our part in shifting to value so that we are always incentivized to think about whole person health and helping connect people to the resources that are needed to get access to work, education, et cetera. And we need to screen for connectivity as a part of our social needs screening. To civic leaders like Josh Edmonds here, I think we really need to be thinking about ways to enhance broadband access outside of traditional spaces. Parks, libraries, schools, churches have become good extension points for us in setting up hotspots where broadband access wasn't available. And then finally, I'll close with that same reiteration. Let's make sure we keep an eye on our rural communities. They're often left behind as we make these kinds of improvements across our country, and the needs are significant and specific. Thank you, David.
Thank you very much. You guys have been terrific in keeping on time, and we're going to have lots of time for interaction if we can keep this going. So our next speaker is Jorge Rodriguez from the Brigham and Women's Hospital in Boston.
Hey, can you guys hear me okay? I think okay, great. Yeah. Thank you so much for having me. As I said, I'm from Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. And I'd like to actually share a story a little bit. One of our digital health navigators working with a couple of patients. And so one patient came in, the digital health navigator showed them how to use our patient portal and telehealth. And the patient was really like, wow, this is like the best thing that's ever happened to me. I didn't know this was such a great tool. That's one person. The other person, one of the initial questions we asked them, like, how do you do with email? Do you have email? That person said, I don't have email. I'm perfectly living my life without email. So that sort of brought up a couple of points for me. For the first patient, I was like, how can we get more of that reaction? How can we get more of that sort of excitement for using digital tools for health? And I think it really brought up the question of like sustainability. And I know we've really highlighted a key component of that being funding, but how do we then serve as, just like others have said, as a healthcare system, as one touch point to kind of create a larger spectrum across the social determinants of health. The other component that came to mind is that I had just captured important information about this patient and about this community. And as a healthcare system, and I think in all of our different kind of silos, whether it's in the community or in education, we all capture to some extent the same data. Do you have access to the internet? Do you have access to the computer? And I think there has to be more of an important role to share that data across the community to be able to then go to the FCC or to internet service providers and say, here's the data that our community is facing. Here are the challenges they're facing from all the different perspectives. And we may run across things that have already been mentioned, like digital redlining, that as a united force across the community, we can then go to the healthcare, to the internet service providers and say, like, here's something that we need to address. The other thing it made me think about was all around sort of the role of insurers, or a lot of this we're sort of taking on. A lot of healthcare systems are finding funds from here and there and they're like secret, funding areas that they're taking out of. Those kind of systems are not sustainable. And do insurers should there be a role? Should they be on this panel with us to have that discussion around the role of broadband going forward? And then the last 2 points here were around one, sort of the role of EHR vendors. One of the things I noticed with this patient is they really struggled to use this, tool. Do we need to have EHR vendors as sort of also active participants and active discussants as part of this to say, as we talk about, broadband on the patient side, what about the kind of the needs that they have on the technical side? When you think about the other patient that I had, which didn't like the technology as much, it really highlighted for me the importance of like multimodal care and realizing that for some patients, broadband and technology and everything may not be the right investment to make, right? In the long run, a lot of our goal here is not so much digital inclusion, which I think it's important, but for us, it's like health equity. That's ultimately as a clinician what I care about. So for some reason, all of my patients have access to all the technology in the world and their diabetes outcomes are not great. Maybe that was the wrong investment to make. So just taking that into account. And the last point I'll make is all around the role of bias. There's been a couple of studies that I've seen that's shown that some patients aren't even offered the patient portal or the telehealth just based on certain demographics. And so just checking our own biases at the door and realizing that you can't really tell a patient's likelihood of using broadband or using telehealth or patient portal just by looking at them and having an important conversation with patients like, this is a tool that we may use. Does this fit for you? I think is another key component to making sure that we can make this sort of a sustainable solution. So thank you so much.
That's terrific. So moving right along, our next speaker is Bill England, who's from our federal government, the Health Resources Administration, and he's going to talk a little bit about what his office does.
Thank you very much. And by way of background, I started in telehealth 25 years ago at CMS. launching the Medicare telemedicine demonstration, then moved to the FCC's Universal Service Rural Health Program before coming to HRSA. Next slide, please. So just in an earlier panel, ASPE gave an excellent presentation of HRSA's mission to ensure equitable health service delivery to a broad segment of America with a focus on underserved and vulnerable populations. This slide shows some of those populations. Because that is our mission, HRSA long ago recognized that telehealth was a critical tool in our service delivery. In quick overview, the vulnerable populations we serve, health centers care for 1 in 11 Americans, almost 30 million people. We operate the primary federal program dealing with people with HIV/AIDS, the Ryan White program. We're involved in serving and improving outcomes for nearly 60 million pregnant women and children through the Child Services Bureau, Women and Child Services Bureau, and we operate a loan forgiveness program for 23,000 clinicians that have agreed to serve underserved populations, and that program has been long encouraging the use of telehealth. Our awards universally allow and encourage grantees to use telehealth, and most of our programs are run through grant programs. Last week, or actually 2 weeks ago, we awarded 29 innovative virtual health grants to foster creative use of telehealth, connected devices, artificial intelligence, and other digital tools for health centers to experiment and transform service delivery models. So next slide. Just very quickly, the history of our office. Again, we've been doing telehealth for a long time. Our first telehealth grants were in 1988. We established the office I'm now in, the Office of Advancement of Telehealth, in 2002. And in 2017, we recognized that telehealth was all over the place in HRSA, and we conducted our first inventory, finding over 1,000 of our grants mentioned telehealth. That's now expanded to nearly 4,000. Next slide. And this just shows where those grants are located. Bureau of Primary Healthcare, which again is health centers, have the majority. And the little yellow slice is actually the office that I'm in, along with the Office of Rural Health, where telehealth started, but we are not by far the lion's share of the telehealth going on in HRSA. It's everywhere. Next slide. Just a quick breakdown, again, looking at our grants, where telehealth is occurring, workforce training being the most prominent in clinical services. Distance learning, we have both distance learning, formerly ECHO services, as well as non-ECHO like activities and clinician support. In terms of clinical areas, behavioral health, substance abuse, opioid abuse are the, by far, primary uses, primary care, COVID-19. Although I will say we don't have our results yet from the 2021 year, so I expect COVID-19 may emerge as the most prominent use. Next slide. And lastly, I'd like to focus on our office, the Office of Advancement of Telehealth. We serve across HHS to promote telehealth, as in our title. We really have two roles. One is to fund grants with our grant-making authority to promote, deliver, and research telehealth. And the other is to serve as an information and assistance clearinghouse. We fund dozens of telehealth networks, 2 telehealth research centers, 2 centers of excellence, and perhaps the best known program is the Telehealth Resource Center. Dr. Ruban, who spoke earlier, oversees one of those at the University of Virginia. These centers are essentially telehealth consultants available at no cost to providers or anyone wanting to start or run a telehealth program. So I invite everyone to take advantage of those experts that we are funding. As a result of the pandemic, we suddenly became interested in the direct-to-consumer telehealth, which was new to us, largely because of pandemic waivers that first allowed for reimbursement of direct-to-consumer telehealth. And that then brought us into how well are consumers connected. And just as a tip of the hat to the FCC, the Universal Service Rural Health Program had done a pretty good job of connecting bricks and mortar facilities in rural areas. And we frankly weren't looking carefully at how well consumers were connecting because that wasn't reimbursable. So we weren't trying to reach them directly. Now we are. So we did launch a new telehealth broadband pilot project, which is allowing us to first begin to look at consumer and provider direct connections in communities to see how well things are working. Lastly, in our role connecting dots for people on telehealth, we opened a new website, telehealth.hhs.gov, shortly after the start of the pandemic, realizing there was no single federal spot for information on telehealth. This is for providers, patients, researchers, anyone to learn about telehealth. Our website is growing fast. And again, I say it's a federal website housed in HHS. I would invite anyone to use the site, and especially for our federal partners, as you have programs, please reach out to us. We'd love to link to your telehealth programs or do whatever we can to link people to the assets that you offer. So I thank you very much for the opportunity to participate in this. I'm learning a lot about what some of our other federal and private partners are doing.
Thank you very much. Our speakers have been so precise and focused that we are going to have time for questions from the audience at the end. So I hope you'll be thinking about those questions as you hear our last speaker, who is Adi Tomer, who's a senior fellow at the Brookings Institution. Adi.
Yeah, thanks, David. Hi, everyone. My name is Adi Tomer. I work at the Brookings Institution's Metropolitan Policy Program, where we've been studying broadband for quite some years. I want to kind of focus on two elements I think hopefully will add to the conversation that, again, the FCC has been so gracious to bring us all together about today. The first one is, how can we make sure that our healthcare industry broadly is focusing on some of the upstream benefits, you could argue, that broadband offers. We're hearing a lot already today, including on this panel, some amazing work happening in telehealth and other community benefits. But we also know that broadband provides immense benefits to other elements around, in particular, two categories of social determinants of health that lead to stronger outcomes in our community broadly, not just in our kind of health-related fields explicitly. So the first one of those is economic stability. We know that labor markets work better with a broadband connection, leading to higher incomes and employment levels. We know that industries grow faster, attracting greater wealth building to regions. Now, if we switch the social and community context, we know that broadband offers leisure opportunities, while social relationships are often strengthened through digital services. Finally, governments are able to operate more efficiently, saving money for their constituents and leaving more resources for other essential services. Now, obviously, on this panel, we didn't talk about education today, but I think it's pretty obvious during the pandemic how much we've learned, both good and bad, about how broadband and education intersect and what that can mean, again, for social determinants of health. When I'm done talking, because I cannot do two things at once, I will post a link to an academic resource we did with our colleagues at the National Digital Inclusion Alliance, which was actually made possible by the generous support of the Robert Wood Johnson Foundation, that includes a ream of academic research focused on social determinants of health that I think could be a great reference for all of you. So again, moving forward, I think focusing on how can you work in communities for those upstream related benefits that we know can deliver stronger health outcomes. The second quick point I want to make is based on how can we think about place-based community health policies. And I want to give you a specific example here. Our team at Brookings is actually getting set to release some new research where we've been able to map at the neighborhood scale where digital food delivery services are effectively delivering food, or where their service maps are. The data is overwhelming on this, but there's a key stat for this audience today. 90% of residents of quote unquote food deserts in the United States receive at least, or have available to them at least one digital food delivery service, right? So you can think of these by names. This is Amazon Fresh, this is Walmart, Uber Eats, et cetera, right? Think about that. 90% of people who we traditionally think in analog terms have an inability to access food, and how that can, of course, impact food security. We actually have a lifeline now through digital food services. But of course, this raises different issues. And we know that some of the same barriers to physical food access, brick and mortar, these quote unquote food deserts, are the same features or conditions that tend to lead to the digital divide, whether that's in network maps or actual inability to afford services. So this is a remaking concept for folks who work in this area. If you're at the nexus of food security, public health, and broadband, how can we make sure that we can tap these transformative and innovative technologies to deliver better results? Again, the theme here, how can we deliver place-based policies that improve our neighborhood level conditions, that improve public health outcomes, and again, ideally lead to a more prosperous future for all. So again, thank you for the opportunity and looking forward to questions.
That's terrific. So do any of the panelists have questions for one another based on what they've heard? If not, I will jump in with a couple of questions.
I have one, David.
Okay.
And I guess this is probably for Josh and for Eddie. When you think about place-based investments in broadband, how much can be facilitated at the municipal city level? And what gets, or do things get in the way from a federal level? Is this a local issue or is this a national federal issue?
Well, I'm going to be definitely biased here and say it's a local issue. I think that it actually is our job in the local ecosystem, at least now, to actually have a much more facilitative conversation around broadband and what that means for us. I know that we, the city of Detroit, are going to be releasing a broadband master plan in very short order within the next few weeks or so, because again, I think that's just our responsibility. I think that out of all of these challenges we're seeing on the broadband front, as we're looking at telehealth, workforce, education, whatever other sector we want to throw out there, at some point we have to stop saying like, oh, woe is us, and really say, no, this is our responsibility. And as there's funding that's being allocated, we have now set up the strategy moving forward that when those dollars reach the municipality, people are now informed of exactly what we're buying and exactly why we're doing what we're doing.
Yeah, I would just quickly add, and John probably has thoughts here too with this incredible research over the years. For those of us working in Washington or focused on the federal government, it always feels like, oh, well, they can invest more, they can solve all these problems at once. But I always default to infrastructure is solved at a local level. I mean, and it is, you want to plan for it at a local level because conditions are always different. You've got to think about capital flows to invest in it. And of course, broadband gets really complicated because it's privately owned, but we want public kind of outcomes, if you will. And then what are the relationships with the states, which tend to actually be the big players here? So we've got an exciting moment ahead of us, as everyone who's probably attending today is well aware. We're investing right north of $60 billion in broadband, everything from boosting the affordability program, $42.5 billion that's going to drop on states to build out networks. But the value of those decisions is going to be decided locally on what our ROI is and how it kind of changes what the future looks like. I think you said it really well, Mikkel. Like this is, calling a utility is actually a loaded term, as folks at the FCC know, but no, I'm glad you did for what it's worth. But what I think we can all safely say, this is essential infrastructure. This is no different than our great-great-grandparents being like, you can imagine them proverbially sitting around like a fire of like, is electricity is that like a future thing? And it's, obviously yes, right? That's where broadband is right now, but we've got well north of 10, if not 15% of households are disconnected per ACS data. And I mean, if that was our electricity or safe drinking water rates, it would become immediately our number one priority as a country, honestly, for domestic policy. And we need to treat broadband as similar. But John, you might have something to add too. I don't want to put you on the spot.
Just one observation I'll make is the role of planning. The infrastructure bill sets aside $65 billion for broadband, $42 billion is infrastructure, $14 billion for connectivity for those who can't afford broadband. It also requires states to do broadband plans and to do digital equity planning. And my suggestion for people attending today is get healthcare systems involved in this process. That will contribute to closing these gaps and closing it in a coordinated way. So you're making not just a dent on broadband subscriptions, which is a means to an end, but having your voice heard in the objective of broadband, which is in this context, better healthcare outcomes.
So the conversation about money and infrastructure leads me to ask a question implied by John's presentation about trust. And the question I have is whether trust is, or lack of trust, distrust is equitably distributed, or whether it's concentrated. Because if we provide access, but people don't want it, that's not going to be sufficient to overcome the digital divide. Any thoughts from our panelists about that?
I mean, I will quickly say that it is definitely very prevalent in low-income populations and among those least likely to have any digital resources. So I'm going to leave it at that. I'm kind of wondering whether Joshua has a perspective given his experience in the city of Detroit on this.
Yeah,
Sorry, Josh.
No, you're spot on, and yeah, like there's definitely huge, like, so, and I think that's like deconstruct trust as much as we can, given the time. So when we're saying trust, it's not necessarily like walking across a bridge and trusting if that plank is going to break. It's not that. It's more so trust from the standpoint of there's been so many promises that have been made by so many other people that by the time you make this promise to do whatever to me, what's the point if everyone else has let me down? And I think that when you couple that with people having to enroll in programs that constantly have to, make someone prove how poor they are and constantly have to showcase why, for example, I need to enroll in this service and this provider, for example, ruined my credit. There are things like that, like when we are now trying to build these relationships with people or advocate on behalf of people, that's where like this trust barrier starts to really manifest. And so I think that, to the extent of when people are throwing out the terms equity, it's like, okay, to be very clear, when we're doing that type of work or we want to look at health equity at the intersection of digital equity, there really needs to be that historic lens at which we view things and say, does your offer counterbalance people's historic experience? And if it doesn't, then that's not really necessarily trust in the way that, people are perceiving it to be, but in reality, it's going to be more so a historic perpetual state of people being let down. And quite frankly, the wrong that we're giving them with respect to maybe an internet subsidy isn't really enough to justify someone wanting to climb out of wherever they are. And so I think that that's really what we're seeing as a reality where we are in Detroit. I know that a lot of other, cities and locations that John is referring to with the data, that justifies that experience as well.
So obviously you overcame that to some degree in your program in Detroit, maybe not.
I think we're committed to overcoming it in perpetuity. And as, it rears its head once more, we have a response to it. And I think that that's really what we want to have in Detroit. And I would say that should be the North Star for a lot of people, is building, responsive ecosystems that, are really rooted in justice-involved work. And so, like, if we're being responsive to the needs that we're seeing, that's not to say that we're going to get to, now we're at zero needs. No, but as there's needs, we have solutions that are really rooted in rectifying scenarios.
And Mikkel, just to contrast Detroit with the rural West, is this an issue for the members and patients of Intermountain Healthcare?
It certainly is. We talk about trust actually as something. Is it transactional, or is it something that builds over time? Do I have a relationship with you for a moment to accomplish something specific, or do you care about my well-being over the course of time? And this is an example of that. I think we've got to figure out how to build. We've learned that community health workers who are from community are the most trusted resource for getting people online, whether it's getting them online or helping them with other assistance or assistance through a church or something known, as opposed to someone who's got a transactional something to accomplish, like a telehealth visit. That's not going to be a long-standing relationship. So this work has to be accomplished through those trusting built relationships.
And here we thought the problem was technology, and it turns out to be humans.
Yeah.
Amazing how that happens. I have a question about the two folks who represent Mikkel and Jorge, who work or in and around healthcare systems. And that has to do with the role of our mostly private providers of healthcare services in this broadband connectivity domain. And I guess one might argue that to the extent that this is a matter of infrastructure, that is just laying the cable right up to through the last mile, through the last 10 yards, that's not something that we expect health systems to do. But maybe there's something else that health systems can do and take the initiative to do. So I'd be interested in your thoughts about those things.
I'm happy to start. Yeah, I think that always goes back to my thought around like sustainability. I think, in intra pandemic as we are, there's been a lot of big push to like healthcare system providing internet and devices and all these things. But in reality, that's not a sustainable model. And I think in building off of that trust piece, it's tough to say, I'm going to provide you for a device, but it's only going to be for X amount of time because it's related to like some healthcare outcome that I care about. And that again, sort of doesn't build a great trust with a patient. And so I think when it comes to sort of building this out, the healthcare system really becomes a point where we can engage with folks like Josh and others on the call to say, can we connect you to the Affordable Connectivity Program? Is that sort of the initial touch point, and then connect you there and then create a more longitudinal approach? And I think as we've seen with some of John's data, that hasn't necessarily been the case because the uptake hasn't been as robust. And so I think as a healthcare system, we can really serve as a point where to leverage and use that relationships that we build up with patients. They put in their hands like their lives to some extent. And so we can really use that to say like this technology will help us to achieve that goal of health. And so how can we connect you with community organizations and community tools to be able to get you there and more of a sustainable model? So that's often what I think about, sort of like creating something that's sustainable that moves into the community rather than just like, here's a device I'm giving you for 6 months and then please give me the device back because your hypertension is better.
So in that sense, it becomes part of the general conversation about social determinants of health and how we supply those or overcome obstacles to healthcare that are written into our social services and our general resources available to people: housing, food, transportation, income, education, all those things that so impact the daily work of healthcare providers.
I would add, David, in a little different dimension, I think health systems also have a role. Providers, whether it's a rural hospital or independent provider or a health system, have a role in their community to speak up on the importance of connectivity in advocating for the growth of their own services, but also advocating for the importance of it in helping address these determinants of health to begin with. So, we might need broadband connectivity, that last mile, to provide services ourselves, whether it's offering telehealth support to a physician in an outlying community for echo or other access. And we can advocate then for that community to get that access that's available then for schools and communities and so on. So I think our voice as anchor community members is really important.
Right. Dr. England, you are representing a very important agency in the federal government from this standpoint. You can point to a ton of programs that you and your colleagues have initiated and are running. Since I've been a federal official, I know that whenever I was asked about something, I could always point to 10 things we were already doing, but the problems never seem to go away. So as you sit where you sit and say, if only I had or we had these additional ideas, and I know I don't want to get you fired, so I know you're gonna have to be circumspect with this, but what is it that occurs to you that you don't have already? Because you clearly have a lot of stuff going on.
Well, as has been mentioned on by a number of previous speakers, one of the biggest concerns right now is that a number of things that we are doing with telehealth are dependent on waivers, and essentially it's reimbursement. Prior to the pandemic, reimbursement was the main impediment to advancing telehealth. The reimbursement took the gloves off, but frankly, some of the things are still tied to emergency waivers, and as soon as those waivers end, especially the direct-to-consumer home house calls, if you will largely come to an end, but many states have adopted in their Medicaid programs specific provisions that will allow that to continue. So it's going to be very varied by whether the state has provision in their Medicaid program. Certainly, as has been mentioned, the 1134 section for Medicare is going to stop Medicare reimbursement for that. So it's for rural health clinics and FQHCs and much of the service that serves rural areas. That's probably the number one thing on our minds. The second one has been addressed in a number of speakers is we turned on telehealth. It simply turned on a camera and a microphone and said, now we've got a video visit. And that's really not the way to bring, I mean, that's what we absolutely had to do. But now how do we integrate this into the fabric? How do we make digital health part of the tools that all providers are using? And that's cultural, that's social, there's a lot to it. And that's what we're going to be focusing on the next few years, provided we get the reimbursement not to end.
Yeah. So we have 12 more minutes, and I know the MITRE folks were going to curate a few questions from the audience. If they've done so, I'd welcome that right now.
Sure. Thanks, Dr. Blumenthal, and thanks everybody on the panel. There are several questions that have come in, and this is Samruddhi Thakur from MITRE Corporation. So I'm going to assume that this question is appropriate for you, Mr. Horrigan, and see if I can pose it to you. But of course, we welcome response from others as well. So an anonymous attendee is asking a question. If we are to look at broadband planning as a local issue, and if existing broadband data has known limitations, what tools or data sets do you recommend to identify local access issues and quantify inequity of broadband distribution? What data sets or applications do you leverage to this kind of planning work? And I know I said the question can go to John, but also I think Joshua, I am certain you will have inputs as well, and any others. Thank you.
Well, on the adoption side, the American Community Survey data is granular, although not terribly up to date due to the 2020 data not being collected due to the pandemic. They do have good information on broadband adoption patterns at the neighborhood level in cities. In lieu of that, if you just use census data that has granular information on income levels, you're going to go a long way toward identifying where you have low rates of broadband adoption. On the network deployment side, that's a little bit of a rabbit hole on how well the federal government collects data on where networks are and how fast they are. There's FCC data that is in the process of being improved upon. Microsoft has collected data doing speed test analysis that can be fairly granular. It might be worth reaching out to folks at Comcast. They collect this down to the county level. I don't know if it goes any more fine-grained than that. So I'll leave it at that and let Joshua or maybe Adi weigh in.
Yeah, I'll say, for what we're doing in Detroit, and I just think that a lot of local communities on the data front end, we've been, I wouldn't say we've been absent in the conversation, but I think we've been relying on this data that doesn't really get us the full picture. With that being said, I think that moving forward, as we're even looking in the city, and we're looking at leveraging our ARPA resources to building out, a more robust and more accurate data set. But this is what I would say that we did at the onset that I would say that most communities should do. So the aforementioned data sets that John mentioned, those are absolutely the ones that we should be using. The problem is what I see is people will use them singularly. They won't actually integrate them into one. So what we did is we actually took one and made a base file. We said that, hey, let's actually get every single address in the city of Detroit. And then off of that, let's take these existing data sets that are very valuable by themselves and combine them into its own. And then we create our own specific index. So then off of that, if we were to do any type of surveying or any type of modeling, now we have a more granular set and the most granular data set by just making an incremental incision by doing our own survey over all the existing ones. And so that's what I would say to be like probably the lowest hanging fruit, but that'll get you very, very far down the path, so that as more data sets or anyone else is doing anything else in this vein, you're now able to work off of something that can inform your entire ecosystem.
I'll just quickly add by putting in a plug. I already did it effectively, but for the National Digital Inclusion Alliance, folks at the FCC know them well. Josh, you might too. I mean, they're awesome. And they've got, per the reading the question in the Q&A, they've got the library for you, right? Think of these different interventions, everything from specific data exercises at a regional level to how they're thinking about building up kind of different indices like Josh just mentioned, or actual programming, right? That's trying to address the divide. So go to the experts that are out there. And I think what's great about last kind of quick soapbox point is what's so important about what EJA or the infrastructure law just did is it starts to build out even more capacity inside the Beltway in Washington to be an even better partner to regions and states across the country to build up more capacity here. There's some horribly sweet irony around the most data-driven of our infrastructure having these data gaps. So there's no reason for it. We just need to invest the time and effort to make it better.
Thanks, everybody. I'll go ahead and pose a question that had come in on an earlier panel, but I do believe it's relevant to bring up here. So Adam Gibbs had asked a question earlier. Are clinicians embracing the transformation of the healthcare model that include telehealth, digital health innovation, while understanding the social determinants of health? If not, how do we get them to embrace changes? And I'm going to request probably Dr. Rodriguez for you to take this one, and I will also request Mikkel to address it as well. Thank you.
Nope, I'll go first. Yeah, I think that, I think as the pandemic has gone on, people have gotten more comfortable. There's been a general sense of there's a role for this. But I think it depends on the clinician, what kind of care you're providing. And as we saw in some of Bill's data, right, the use of telehealth sort of varied by different kind of specialty in what you were doing. So I think some specialties have taken this and run with it a bit more. Others have sort of started to find what the best application of these tools are, and then and seeing how patients do with them. But I think they've all kind of come to understand whenever you talk about these things, it's the digital divide sort of always comes up. That's the thing. I was wanting to use it, but the digital divide, and this would be great, but the digital divide. And so I think there's a general sense that there's value here, and there's a potential tool here, but it has to be sort of within. And not to say this is all just if we had the greatest infrastructure and broadband was super affordable, it would be solved. There's also a lot of things on the healthcare system side in terms of workflows. One of the classic examples is sort of integrating interpreter services into telehealth visit, and what that does in terms of facilitating and making it useful for patients and for clinicians. And that goes into a whole other conversation around sort of interpreter resources, but that's a story for another panel. But I think a lot of it has to do with sort of addressing digital divide, but also establishing healthcare system side workflows that sort of support the use of these tools in just like you would seeing a person, inpatient, or what I'm doing right now, seeing patients in the hospital. So I think that's what I'd say.
I would add that early on, a lot of the resistance we encountered for using telehealth and digital tools was this idea that it would create a greater fracture in an already pretty fragmented health system. And how could you really use this technology to create more of a continuum of care? And so as we've gotten better and better at this, we're more so using telehealth to connect parts of the health system to one another and create a cohesive and comprehensive experience for the patient that keeps the patient closer to home, keeps even care delivery closer to home, but doesn't create isolated visits that don't add up to something of improved overall care delivery for patients. So for example, by offering in our collaborations with schools to set up telehealth capability in the school and offering to parents to consent for their children to be treated by their own primary care physician using that telehealth technology, then going to the provider community and offering every physician in that school district the opportunity, who's in primary care, the opportunity to join the telehealth capability network. Almost all say yes, because they want nothing more than to care for their kids wherever it's most easy to do so. And parents want the same thing. And at the same time, we offer a backup. That you can connect to a telehealth urgent care if that primary care physician isn't available. But by building networks that really foster the continuum of care and that connection to a medical home, I think we are seeing a lot greater adoption and appreciation of this additional resource.
Just adding briefly to that, we ran a telehealth network focused on clinics and schools a few years ago. Focusing again on many of our clients, that may be the best place to encounter healthcare is in the school, but we focused on things that the school said were the most important: asthma and weight and drugs and other things that the school said the clinic needed to do. What we found by studying it was primary care was the main thing that the kids needed at the school. We weren't really expecting that because that wasn't even one of the criteria that we listed in the application. But yes, I mean, schools, a great example of this is a place we can deliver healthcare and improve outcomes simply because of the availability of kids that may not get into the clinic.
So as someone who practiced primary care for off and on for 35 years in rural downtown Boston, in one of the most wired health systems in the United States at that time, when they created 3 of its own electronic health records, I can say that physicians are get comfortable using electronic technologies, but they don't view them as social determinants or their responsibility to make sure that their patients have that resource. And since our conversation has been about this as a social determinant, that is not something that medical professionals, healthcare professionals view as traditionally as their responsibility any more than they view transportation, education, income, food, or health literacy as their responsibility. So we still have some work to do to draw broadband access into the psychology and understanding of America's medical providers, healthcare providers. I think we're at time now, and I don't want to take someone else's time. So I will thank our panelists. It's been a great panel, great diversity of perspectives, and pleasure to meet you all. And thank you for the work you're doing.
Terrific. Thank you very much.
Thank you.
Yeah. Thanks.
And thank you again, Dr. Blumenthal and panelists for that outstanding discussion. Ladies and gentlemen, we'll take a brief pause before we start the 5th and final segment of our symposium. We will resume promptly at 3:35 p.m. Eastern Time. Please watch the time counter on your screen to remind you when our symposium will resume. Thank you.